You can be introduced by Dr. Ilya Grigoriev. He attend us 5 minutes later.
Okay.
Hello, hello.
Hello. Hey, Mario. How you doing?
I'm fine. What about you?
Good, good.
Early morning for you. What time is it there?
4 o'clock.
Oh, it's very early.
Neurosurgeon's hours.
Yes, 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 yes.
But I only do them once in a while. I don't do them every weekend. Just once in a while.
Understood.
Yeah. Do you know Takashi? Takashi's from Japan.
Hi, Kashi.
Japan.
Nice to meet you.
Nice to meet you. I'm Dr. Kon from Tokyo, Japan, and I can translate English to Japanese. I try to.
Okay.
Right. You know, he and I are going to travel the world, going to neurosurgery departments in all parts of the world, right, Takashi?
Yeah. So the Russia is a Tumen, from Tumen.
Human, yes, in Russia, right?
Yeah, Tumen. And they're a doctor from Novosibirsk.
No, actually, this is from
Russia?
all over
Middle-
Moscow, based in
middle
Moscow.
of Russia, Siberia. And I know some doctors from Krasnoyarsk, Dr. Igor. Yeah. Something is wrong with my AirPods.
Your earphone?
I try to. Okay, yeah. It's not now. It's okay.
Okay.
Yeah. It's okay. It's okay. So, if I'm translating from English to Japanese, so sometimes Japanese is heard as a noise, but we talk. I talk as small as possible, not to interfere speakers. So understand it about it.
Oh, okay, very good. Today's the 4th. Okay, 4th. March 3rd. Mario, do you want to speak March 3rd for the China Neurosurgical Journal?
I will be in in India. It's difficult for me that period. I'm
Oh,
returning
okay.
from travels on the 11th of March.
Oh, okay.
I
So,
I can do after that. Yeah.
okay. Okay, yeah, okay, so then, let me guess you while I got you.
Yeah.
Okay, so it won't be the 3rd of March, it'll be the 17th of March. So check your schedule, 17th March.
March, yes, is a Sunday. I can do it.
Yes, okay, good, I'll put you down.
Yes, yes.
Great,
Fine. Thank you so much.
sure.
Perfect.
Hey, very good.
So I think Nargiza might not be able to join today, correct?
No, Najee, no, she can't come. Oh, you met Ben, Takashi?
Yeah, yeah, it's okay. So I'm ready. I'm doing a night shift.
Okay. What time is it there?
What time? It's 6 before 3 minutes before 6 p.m.
Okay.
Japan time. It's okay.
Okay,
Hello.
Takashi, I'm gonna leave you at, hello, Jacob, how are you?
Fine. Thank you.
I'm John Bennett
Hey,
from
Jakob.
Neurosurgery TV.
Hello. Hello. Thank you to invite me.
Hey, well, you're welcome.
Is it good voice?
Yes.
It's perfect.
Okay. Thank you.
Okay, Andre, you ready?
Yeah, I am ready.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett, broadcasting from beautiful Miami Beach. We have another Russian neurosurgery grand rounds. Nargiza cannot be here. Excuse me, Takashi, can you mute, please? We can hear you.
Mute?
Yeah, mute. We can hear you. Okay, that's very good. We're just getting to know the language. Anyways, Andrei Duvoy, MD, he's a Moscow neurosurgeon. He's going to give the first presentation, and he's an avid follower of Zoom. He's very active in Zoom, and we really appreciate his time. So welcome, Andre. It's all yours.
Thank you so much, John. My name is Andrei Dubovoi. I'm neurosurgeon from Ilinskaya Hospital. Now I'm work in Moscow. My presentation about giant cavernous malformations of the brainstem. Today, I present the material from my past working place in Novosibirsk Federal Neurosurgical Center and from this working place from Ilinskaya Hospital, where I work now. I will try to demonstrate my screen.
Okay, perfect.
Perfect.
Excellent.
Okay. What about history of cavernous malformations? First time the brainstem cavernous malformation was removed by Walter Dandy in 1928. But active cavernoma surgery became possible only after wide introduction to the practice CT and MR imaging in 19th of the last century. Prior to this, most cavernous malformations of the brainstem diagnosed only on autopsy. What about epidemiology? According to the literature data, cavernous malformations prevalence ranged from 0.4% to 0.9%. Among them, the prevalence of brainstem cavernous malformations ranged from 8 to 30%. Most common localization in the pons, more than half of all cases, rarely in the midbrain, more rarely in pontomedullary junction, and less in medulla oblongata. The exact occurrence of giant brainstem cavernomas is unknown now. The average frequency of bleeding rate from brainstem cavernous malformations range from 2.4 to 6.8% per year. The bleeding rate from brainstem cavernous malformations is 30 times higher than from cavernous malformations of hemispheric localization. Some authors note an increased risk of hemorrhage from cavernous malformations greater than 1 centimeter in maximum diameter. What about rebleeding rate? Rebleeding risk, according to different authors, varies widely and reaches 60%. It's very high percentage. The more bleedings, the higher risk of recurrence. With one bleeding, the risk about 6%. With two bleedings, already about 10%. The neurological worsening is directly related to the frequency of recurring bleeding from cavernous malformations. In 20% of all cases, the first bleeding is lethal. You can see the bleeding and rebleeding rate. Annual bleeding rate ranges from 2.4 to 6.8%. Annual rebleeding rate reaches to 60%. And rebleedings from residual brainstem cavernous malformation after surgery occurs in 58%, a very high percentage too. Surgical morbidity and mortality. Surgical morbidity reaches 34%, and surgical mortality varied in a wide range and reach 6 and 7%. Non-surgical mortality up to 20%, more higher. Indications for surgery: the lesions reaching pale surface of the brainstem and repeated bleedings 2 times or more. Deep-seated cavernous malformation, accessible VSF entry zones, deep-seated cavernous malformation with rebleedings, resulting in irreversible neurological deficiency or impaired consciousness. The main goal of surgery is prevention future bleeding rather than neurosurgical recovery. And surgical strategy was the balance between the after bleeding morbidity and surgical morbidity. What about timing for surgery? The best time for surgery between 3 and 8 weeks after surgery. In acute stage, between 0 and 3 weeks after bleeding, the hematoma surrounding the cavernous malformation is good for surgery, but sometimes the surgery not possible due to unstable condition of the patient. In the subacute period, the hematoma was liquefied, and liquid blood surrounding the cavernous malformation simplified the dilating of lesion. And the patient condition between 3 and 8 weeks rare is very worse. After 8 weeks, the chronic gliosis and the scar formation around the cavernous malformation became the surgery is very difficult. And after 8 weeks after bleeding is too late for surgery. We use a cavernous malformation grading system by Michael Lawton. The maximum points of this cavernous malformation grading system is 7. We use parameters of size of cavernous malformation, crossing axial midpoint, development venous anomaly around the cavernous malformation, age of patient, and a hemorrhage study. What about radiosurgery of the cavernous malformation of the brainstem? Associated with radiosurgery, mortality varied from 0.4% to 3%, and permanent morbidity reached to 16%. Post-radiosurgery hemorrhages varied from 1.8% to 7.5%. And symptomatic radio-induced complication was encountered in 3%. What about my personal experience of the brainstem cavernous malformation? My personal experience, totally 48 patients, 27 female, 21 male, age from 13 to 65 years, middle age around 43 years. You can see the distribution of the distribution of localization of the cavernous malformation, mostly in pons, in midbrain 6, in ponta mesencephaly junction 6, midbrain and thalamus 3, ponta medullary junction 4, and medulla oblongata 11, more higher than in the literature data. What about timing of the surgery? Most of patients was operated during first 8 weeks after surgery. During first 3 weeks after surgery was operated 15 patients, and between 3rd and 8 weeks operated 21 patients. Only 12 patients was operated after 8 weeks after bleeding from cavernous malformation. 42 patients with 1 or 2 bleed episodes, and only 6 patients with 3 bleeding episodes. I can use different approaches for cavernous malformation. The approach maybe correlate. The approach should be correlated with the location of the brainstem cavernoma, and most number of patients perform suboccipital midline approach and then telavelar approach, one side or both sides. 8 patients was operated by subtemporal approach and 7 by retrosigmoid approach. And the other approach we use more rare. We use orbitozygomatic, pterenal, occipital transtentorial approach, supracerebellar approach, lateral and midline, and far lateral approach too. What about results? Follow-up of our patients were monitored only in 32 cases of 48 patients. It's slightly difficult to monitor all of our Russian patients because the patients sometimes live very, very far from surgical center. You can see the modified Rankin scale before surgery and just after surgery. Most of patients just after surgery, next day after surgery, was worsened, but they are improved in follow-up between 6 months and more later to MRS 1, 2, sometimes 3, and only 7 patients in follow-up was 4 and 5. We don't have deaths after surgery in our series. You can see the female, 4 years old, left midbrain malformation with 2 bleeding episodes, and neurologically she had only right hand hypostasia. Before surgery, she was MRS 1. We perform MRI and functional MRI to determine the fibers and tracts surrounding the hematoma and cavernous malformation. And we perform surgery. We delayed this cavernous malformation. The cavernous malformation was 5 points. We perform a left occipital interhemispheric transtentorial approach to the interhemispheric fissure. I'm disconnected bridging veins. You can see the stage of preparing to cutting the falx, and you can see cutting the falx. And now, after that, we perform arachnoid dissection of the quadrigeminal cistern. After arachnoid dissection, you can see the brainstem pedicle of our side. This is left side. I'm penetrate this pedicle. I use diatherm coagulation with very, very small amounts. Sometimes I did not use diatherm coagulation, and you can see the stage of the dilating of cavernous malformation. This patient was operated in a gold period after bleeding between 0 and 8 weeks. And I am revised the cavity of the dilated cavernous malformation. This is final view. This is MRI after surgery. You can see the dilated cavernous malformation, totally dilated without any parts And the patient 7 days after surgery, before discharge, she was MRS 0. Next case, cavernous malformation of the pons. This is a male, 47 years old, with 2 bleeding episodes. Neurologically, he had right side prosoparesis, right side hemiparesis, 3 points, right side third nerve paresis, and she was MRS 2. Total points of the cavernous malformation grading system was 5. You can see the small video, midline suboccipital approach, mapping of the bottom of the fourth ventricle. Then we perform the approach into the safety entry zone, and then we remove cavernous malformation. Next day after surgery, you can see MRI without cavernous malformation. Just after surgery, he had MRS 2. Just after surgery, and 1 month later, 3 months later, he had MRS 1. Only right side prosoparesis, half bracken 1. This is a very interesting case, female 13 years old. This is the youngest of our patients with cavernous malformation of the pons. This is a giant cavernous located at the floor of the fourth ventricle with 2 bleeding episodes. Neurologically, she had tetraparesis 3 points, both side prosoparesis, house bracken 4, bilateral hemihypoesthesia, complex bilateral eyeball disorders. She was MRS 4. Total points of this cavernous malformation grading system was 5. Sometimes it's very difficult to determine the true size of the cavernous malformation because the surrounding hematoma determines the overall size of the brainstem damage. In these cases, we can perform MRI after resolving of the blood, maybe 1 month after this episode. MRI next day after surgery. You can see the cavity of the dilated cavernous malformation. We performed the occipital approach, and both sides stellovelar approach for deleting this cavernous malformation. Just after surgery, she was worsened. She was tetraplegia, both sides prosoparesis, tetrahypoesthesia, and bilateral complex eyeball disorders. During 5 days, she was intubated. Then she was extubated, and 5 months after surgery, she recovered to MRS 1, moving in extremities fully recovered. Right side prosoparesis recovered partially to half bracken 1, and sensitivity completely restored. She had only right leg ataxia, and she was continuing to study at school. Next interesting case, 30 years old female with cavernous malformation of the pontomedullary junction with 2 bleeding episodes and only bilateral 6 nerve disorders. We counting this cavernous malformation grading system as 4. We perform midline suboccipital approach of the both side of the televelar approach, and removing the cavernous malformation through the bottom of the post ventricle. MRI, you can see MRI the next day after surgery. After surgery, she had a bilateral prosoparesis, internuclear ophthalmoplegia due to medial longitudinal fasciculus palsy, and both sides hemiataxia. But 7 days after surgery, she tried to
Так ты не отпускайся сильно-то. Меня ж нет.
to move in without any persons who helping her. And you can see 2 weeks after surgery, this patient, she moving more good than 1 week before. You can see 6 months after surgery MRI. After 6 months, she had only left hand hemiataxia, the cavity of the dilated cavernous malformation. And 1 year after surgery, she was MRS 0 and returned to previous work. The cavernous malformation of the midbrain and pons with 3 bleeding episodes. The most difficult case from our series. The female, 42 years old, first bleeding episode. After first bleeding episode, she had bilateral third nerve palsy, mostly right side and right side hemiataxia. After second bleeding episode, she worsened to MRS 3, and she had both legs paraparesis 3 points and dysfunction of the pelvic organs, worsening in oculomotor disorders. After third bleeding episode, she was already MRS 4 with deep paresis in the right arm, left arm ataxia, lower paraplegia, both sides painful anesthesia of the forearms, and bilateral third nerve palsy, right 4 and 6 nerve palsy. You can see this is a giant lesion located on the pons. You can see the cavernous malformation located not only in pons, in the midbrain too. And she was with venous anomaly too, and she had grade. She had 7 points of the grading system. We perform surgery for dilating this cavernous malformation. We perform supracerebellar midline approach to the cavernous malformation, and you can see MRI after 2 weeks after surgery. We preserve a venous anomaly, but patients worsened after surgery to MRS 5. Before she was MRS 4. And 1 month after surgery, she started recovering. She was 2 points in lower extremity and 3 points in upper extremity. She had a mild regression of left third nerve palsy. And she had a regression of the right 6th and 4th nerve, slightly regressed. But she was tracheostomy and gastrostomy. 1 month later, she was decannulated, and now only 5 months after surgery, and the patient was a gastrostomy. And she had a tetraparesis. This is unsatisfactory result of our surgery. What about complications? Early complication before 1 year after surgery. 20% of 48 in our series worsened their neurological status in the early postoperative period, first 1 week. But restored it to the preoperative level or even improved it over the next 1 year. You can see the list of complications, early complications in our patients in both in all locations of cavernous malformations. And we have 2 cases of late complications 1 year after surgery or later. We have 2 patients with hypertrophic olivary degeneration. Both of these patients with cavernous malformation located on pontomedullary junction. Hypertrophic olivary degeneration develops in patients with lesions located near the superior cerebellar peduncle, through which fibers from the cerebellum pass and connect to the mesencephalic right nucleus, suggesting that disruption of the dentarubra connection may be a major cause of hypertrophic olivary degeneration. You can see in this case in both sides hypertrophic olivary degeneration, and in this case in one side only. The most significant factors for a good outcomes of surgery for giant cavernous malformation of the brainstem is exophytic growth of the lesion, lesion not crossing the axial midpoint, surgery in a stable patient condition, timing of surgery between 3 and 8 weeks after last bleeding episode, and patient age less than 40 years. In conclusion, cavernous malformation of the brainstem are complex pathology that requires microsurgical treatment since its are significantly lower than the risk of the natural course of the disease, and then the outcomes of radiological treatment. It is necessary to have connections with specialists, psychologists, speech therapists, ENT doctors to resolve problems that may be after surgery of brainstem cavernous malformation. It is more advisable to perform surgical treatment in the interval between after bleeding, but it is also possible in acute period up to 3 weeks if the patient's condition is compensated. Surgeries later than 8 weeks are associated with a higher percentage of surgical complications and morbidity. Thank you for your attention.
Okay, Andre. Thank you very much. Let me get you off the screen there. Nargiza is not feeling well, I guess. So we'll kind of wing it. Any questions or comments from the panel?
Well, I would like to congratulate Andre. This is a wonderful presentation, really very educational and amazing cases. There was a slide in which you were discussing some strategies to reduce the grading and improve basically the likelihood of a good outcome. Can you basically discuss this a little bit more in details? What can a surgeon, other than identifying the right time frame between 3 and 8 weeks, do to increase the likelihood of a good outcome?
Yes, thank you, Mario. Yes, this is a best period between 3 and 8 weeks because sometimes just after bleeding, the patient condition is not very well. And after 8 weeks, the surrounding gliosis and surrounding scar around the cavernous malformation can
prevents from having a natural cleavage of between the lesion and the surrounding brainstem, right?
Yes, we don't have a dissection plane between cavernous malformation and the tissue of the brainstem.
And in terms of your case series, how many of them were exophytic and
I don't know exactly about percentage, but we have only few patients with exophytic growth.
Yes. What I noticed is that even in some of the cases you presented, I had the impression, oh, we are lucky, this is coming to the surface. whereas you had to identify a safe entry zone because it was not visible. There was no dyschromia. There was no evidence of the cavernoma reaching the surface. So one has always to be prepared to use intraoperative neurophysiological monitoring to identify the best path. Yes.
Yes, thank you, Mario.
Wonderful presentation again. I'm really pleased we had you today. Wonderful. Thank you.
Thank you. Thank you.
Any more questions,
Hello.
comments? Go ahead.
Yeah.
Go ahead.
Hello, everyone. So please excuse me for being late. Hello, Professor Andrei Dubovoy. Your cases are fascinating, like always. I want to ask you one question. Would you advocate the surgery for a 33-year-old male or female with full neurological recovery and 1 month after the initial rupture, its first rupture?
Your question about 13 years old female, yes?
33, so mid-aged. 33 years female with pontine cavernoma.
Yes, 38 age female with brainstem cavernomas malformation.
Yeah, 1 month after the first and initial bleeding and fully neurological recovery after the initial bleeding.
Yes, she was fully recovered, but she suffered two surgeries on her eyeballs for correct third nerve palsy.
Oh, okay. Now I want to ask you if you advocate a surgery for a woman. In my mind, I have a 33-year-old woman with brainstem cavernous malformation rupture, and I wanted to ask you if you advocate a surgery for the patient with within the 1 month after the initial cavernoma rupture and fully neurological recovery.
Yes, we discuss with patient about possible complications after surgery, and we ask about sometimes lethal episodes after surgery, sometimes worsening in many functions of the brainstem, and she really wanted to be operated, despite our possible complications after surgery.
Thank you very much. Thank you very much.
Okay, any more comments, questions? If not, I believe, Igor, are you taking over hosting?
Excuse me, we have one question from the Takashi.
Oh, go ahead.
Yes, I'm Dr. Kon from Tokyo, Japan. Thank you, Dr. Andrew Dubovoy, for the great lecture. And as for cavernous angioma, so we try to with the dorsal side mainly suboccipital approach, but do you use supracerebellar infratemporal approach or subtemporal approach, inferior subtemporal approach? So you try the bit very hard, the route is very complicated.
Yes, we tried to use a subtemporal approach if the lesion located in the side of the brainstem, in the lateral surface, and if the lesion located in the middle of the brainstem, for example, in ponta mesencephalic junction, we use subtemporal
approach. Okay, thank you. Spasibo.
Thank you.
Okay, very good. Okay,
and I have another question. If
go ahead.
Professor Dubovoy, what is your impression about the radiosurgery of cavernomas?
I think is not very good option for brainstem cavernomas. We don't have a target for radiation. The target for radiation is smooth muscle cells, but cavernous malformation doesn't did not exist smooth muscle cells. And radiation is not so good option, I think.
Because in some literature, some some doctors advocate the radiosurgery for brainstem cavernomas, but as the neurosurgeons know, and I could of course agree with you, there is virtually no place for radiosurgery in these difficult cases. There is only place for microsurgery.
Yes, I think so.
Have you ever operated patients from after the radiosurgery?
In my series, I didn't have in brainstem location. In other locations, I had.
And is there any features in the surgery, like more scarring around the cavernoma or something like this?
I don't understand.
Is there any features after with the surgery after the irradiated cavernomas? Because in my surgical cases, I don't have operated the irradiated cavernoma, so I don't know. Maybe there is some surgical features, like more scarring or something like this.
Yes, I understand you. In brainstem cavernous, I don't have these cases, but in other locations, I was operated sometimes after radiosurgery, and the gliosis and scar after the radiosurgery around the cavernous malformation is very hard and very difficult to have a dissection plane between gliosis and between cavernous malformation. It's very difficult to remove these lesions after radiosurgery.
Thank you very much. And we have two other questions from the Mario and Jakub.
Yes, from my point of view, I just wanted to mention the indication for gamma knife radiosurgery. Obviously, this has been extended since we had the introduction of the new machine perfection, which can go a little lower on the foramen magnum, 1 centimeter below the foramen magnum. However, the indication is only for those lesions that are so tiny they might prove challenging from a surgical point of view. Cavernomas that are 5 millimeters or less might be suitable for gamma knife radiosurgery. It is assumed that if they are deep located, the destruction that you might create by microsurgically attempting a removal is higher than the possible risk of side effects related to the radiation treatment.
Okay, very interesting. Thank you.
Thank you very much. And Jakub?
Hello, everyone. Thank you, Professor Dubovoi, for your great presentation. Really, it was great. I just have one question. What's about propranolol? If you have any experience to use propranolol for non-rupture cavernous malformation, any benefits did you see? Because as we know, many presentation, many publication is coming about propranolol for during the non-rupture cavernoma to follow.
Okay, Jakub, I understand your question, but I don't have any experience of use propranolol in cases of cavernous malformation in brainstem localization and other localizations too. Do you have experience? That experience?
Actually, I am from small country. Even during my life, I saw very few cavernous malformation. That's why it's your job. You have a big country. Okay. During the year, I saw maybe 1 or 2 cavernous malformation.
Okay, understand you. Thank you. Yeah.
Thank you.
We saw this small amount of cavernomas too, because they all are at the Andrei Dubovoi's operation room. And of course, if we have not a neurosurgical TV, but radiosurgery TV, we advocate the different position. We could say that the radiosurgery is better for all cavernomas.
Okay.
Thank you very much.
Thank you
Very,
for all.
thank you, Andre. And Ilya, why don't you take over as moderator? Can you do that?
Yeah, thank you very much. I would introduce the second international speaker is Dr. Ravi Mohan Rao from the Bangalore, India, and his topic is microsurgery for intracranial AVMs. Dr. Ravi, please go ahead.
Thank you very much for your kind invitation. It's a pleasure to be back. I was there last month presenting my experience with epilepsy surgery, and it was a great experience. And thank you very much for allowing me to present again on my experience with microsurgery for intracranial AVMs. I'm sharing my screen.
Okay.
Is it visible?
Yes, not full screen yet. Presentation mode. Yeah. Okay,
It's
perfect.
So thank you very much. I work in Apollo Hospital, Bangalore, which is a corporate hospital. And this is my neurosciences team, which includes neurologists, neurosurgeons, anesthetists, neurotechnicians, and interventional neuroradiologists. The AVM resection rules are standard and is very much aware to all of us. We study the MRI and DSA in multiplanar sections, study it very closely to form a strategy to, when we have decided to operate on an AVM, we have to evolve a strategy like a battlefield strategy to secure the arteries first, circumferential dissection. In order to do this, the approach should be adequate, giving the exposure which is required for dissecting the AVM safely. The arachnoid dissection is done around the AVM, securing the arterial feeders one by one. Of course, the surface feeders can be secured first. The problem is with the deeper feeders coming from the perforators, which come towards the end and can give troublesome bleeding at the end of surgery. The cardinal rule is circumferential dissection of the AVM in as close to the brain AVM plane as possible, securing the deep feeders, finally securing the venous pedicle. Following these rules is essential to avoid entering into the AVM nidus and having troublesome bleeding during surgery or interrupting the vein, major vein, draining vein before all the feeders have been sectioned, which can give rise to catastrophic hemorrhage during surgery. So I straight away go to some examples. The first patient is a 17-year-old male studying in his 12th year in school. He had seizures in 2016 with no focal neurological deficits. This is AVM located in the left superior temporal gyrus, posterior end of the left superior temporal gyrus. AVM coming to the surface, not a very big AVM, around 3 centimeters in size. And the fMRI showed that the language area was predominantly behind and in front of the AVM in the temporal lobe. This is the angiogram showing that it has feeder predominantly from the MCA, maybe a single feeder giving rise to the AVM, and a single draining vein into the superior sagittal sinus. So as I said before, the maximum diameter was 3 centimeters in size, and it was adjacent to the speech area presenting with seizures. The annual risk of bleed in this patient age 17 years is around 2 years. Cumulatively, this could have a higher potential for bleed during his lifetime. The risk of developing epilepsy is around 10 to 15%. So we discussed several options with the patient's family, which included conservative management with anticonvulsants, stereotactic radiosurgery, and microsurgery. The patient's family did a lot of research and finally chose surgery. And when we discussed about the risk to language, they were agreeable for an awake craniotomy, language mapping, and excision of the AVM. So this is during the awake craniotomy.
Okay. Now, what does the king wear on his head? What do you see time with? Make it 6. What does the king wear on his head? What does the king wear on his head? He's getting clonic movements, right side. And speech errors. On what do you sleep, upper man?
So we did the language mapping. This is the AVM seen at the surface coming to the pia-arachnoid surface. This is the draining vein. The feeders are inside the sylvian fissure. This is the temporal language area posteriorly. Anteriorly, there was no language. These are the frontal language areas. And this is the surgery video. This runs for about 8 minutes. I'll fast forward it during sometimes to save time. The arachnoid dissection being done. So this is the en passant artery from the middle cerebral artery. This is actually the M4, but it's hypertrophied because it's supplying the AVM. We go around serially ligating the branches. So you can see this single vessel is giving rise to multiple branches feeding the AVM. So this step is very crucial, serially ligating the feeders, preserving the en passant vessels. So from the undersurface of the en passant vessel to there were feeders which were entering the AVM. So the en passant vessel is being mobilized to see if any more feeders are there. This is the mobilized en passant vessel. This is the draining vein. And you have feeders entering the AVM over the draining vein too. These are the two feeders. I sometimes use the temporary clip on the main vessel to facilitate identification and ligation of the feeders. Use it for short whiles. And this is the AVM nidus, buried in part of the superior temporal gyrus. So this was a sulcus separating the AVM from the speech area. That made the surgery a little bit easier. So to do the circumferential dissection, parenchymal dissection is essential. This is the parenchymal dissection which is being done as close to the AVM nidus as possible without entering the nidus. So this is a fine balance on a knife's edge, not entering too much of the brain because in eloquent region that can cause a deficit and not being violating the AVM nidus. So the AVM nidus is slowly coming into view. This is the gliotic plane, some hemosiderin deposition is seen. Though the MRI didn't show any evidence of bleed, the seizure is probably because of this micro bleeds. So as dissection is done further, you see more feeders very close to the AVM nidus, entering the nidus. This is the hemosiderin staining which is seen. And when I was coagulating the surface, then suddenly a part of the AVM ruptured and bleeding appeared. Tried controlling it with coagulation. And then I had to apply cottonoid pressure for some time in order to stop the bleeding. Because this was a low pressure leak, the cottonoid pressure was sufficient to stop the bleeding. And then the deep feeders come into view. These deep feeders have very fragile vessels and they rupture very easily. As you see in this part of the video. The problem is when the bleeding edge retracts into the white matter and you chase it, that can be a cause of neurological deficit. There's another of the deep feeder. So you see there the deep feeder bursting again on trying to coagulate it at even low currents. So I choose to use a Liger clip on the deep feeder and then coagulate and cut it. This is the AVM nidus being mobilized. And then the nidus is hinged on the pedicle, which connects to the venous drainage, and the AVM is excised. And this is the M2, which is seen in the depth of the Sylvian fissure. This is the fluorescein angiogram. Of course, this can't detect any buried AVM nidus, but as the whole thing was in the cistern, may give a good indication that we have removed the AVM completely and there is no residual AVM. This is the post-op angiogram showing full excision of the AVM. And his reading writing post-operatively is normal.
What you are studying?
These videos are being shown with the permission of the patient.
But last week, a bizarre incident came to the organization's office. A pet shop in Rajaraj.
And he passed his 12th exam with flying colors and is studying further.
No, which subjects you wrote? I wrote English, Hindi, science.
So eloquent region AVMs can be safely resected with proper planning and execution. Of course, this is not a mandate for tackling all eloquent region AVMs. Many of them are treated by radiosurgery, and we did offer radiosurgery to this patient, which was refused by the family. The second patient is a 28-year-old female who presented with sudden onset of headache and progressive left hemiparesis due to this bleed, which you see in the temporal lobe extending into the external capsule, the insula, and the outer basal ganglia. The patient developed in the hospital after admission progressive left hemiparesis. And this is the angiogram showing an amygdalar AVM being fed by the MCA with a draining vein. And we took up the patient for targeted embolization. There was a feeding artery aneurysm, which was probably the cause of the bleed. And onyx embolization was done to eliminate the weak point in the AVM before surgery. And during the embolization, unfortunately, there was onyx reflux into the MCA, cutting off the MCA. Immediately, balloon angioplasty was done and the continuity of the MCA was restored. This is the operative video. I'll skip it in view of time constraint. And this is the post-op angiogram showing complete excision of the AVM with some onyx material seen here, but no AVM neither seen. There was also an M2 aneurysm which was clipped during surgery. She got back to work as an IT professional. She's now married, runs half marathons, and is back to normal life. Neurological deficits in AVM with bleed are potentially reversible. Preoperative embolization can make microsurgery safer, but be aware of potential complications of embolization, and should they occur, it should be handled immediately on the table. The next patient is a 44-year-old female who presented with sudden onset of headache with left hemiparesis, which improved. The cause of the hemiparesis was this bleed in the corpus callosum and the cingulate gyrus, and this is the AVM, which is seen in the MRI. This is the AVM nidus. This is the angiogram, which shows the A2s feeding it, and there were 4 feeding artery aneurysms in this patient. At that time in that hospital, I had 3D ultrasound sonovan, which was used for localizing the feeders and the draining veins during surgery, apart from navigation. The interhemispheric approach was made, and these were the huge draining veins which were seen during surgery. And this is after excision of the AVM. You see the AVM nidus has been almost completely excised. I didn't clip the aneurysms at that stage. However, a very small portion fed by the lateral lenticulostriate artery residual is seen here. So this was the only remnant of the AVM which was seen. We referred the patient for gamma knife for the small residual AVM, and this is the angiogram done during AVM. The aneurysms remain the same size, though the vessels have returned to normal size. At 7 years follow-up, 4 years after GKS for the deep component, patient is doing well. She was a good painter, but has not resumed painting after these bleeding episode and AVM surgery, GKS, etc. She now has refused post-GKS angiograms and any treatment for the flow aneurysm, which was advocated at the time of doing gamma knife surgery. So this may be a debatable conclusion. Flow-related unruptured aneurysms in high-flow AVMs can regress or lie dormant after AVM resection, and psychological problems can arise after successful AVM surgery, especially in the region of cingulate gyrus. The next patient is a 51-year-old lady who presented with seizures, and this is the angiogram. This is the lenticulostriate supply and weak point in the nidus, which caused the bleed. This is the angiogram. A huge venous varix was present. Taking the venous varix, this was nearly reaching 6 centimeters in size. However, the AVM nidus is this size, maybe around 2.5 to 2.75 centimeters in size. There was also a PCA supply. This is the CT angiogram. So detailed planning was done by the interventional radiologist, including identifying all the feeders and which had to be tackled with selective catheterization to make the surgery safer. This is after targeted embolization. When we use interventional embolization before surgery, the idea is to make the surgery safer, eliminate intranidal aneurysms if possible to make the surgery safer. And this is the post-embolization MRI to check that there is no bleed after embolization or an infarct. And this is the contrast MRI after embolization. The patient was operated. Again, I'll skip this video to save time. And this is the AVM nidus excised. And this is the preoperative CT angiogram. And this is the AVM nidus with the venous varix, and this is the post-operative angiogram. And the patient did well. Initially had leg weakness, which improved completely. And doing very well at 1 year follow-up. So targeted embolization in experienced hands can make microsurgery safer. The last patient is a 23-year-old female who was studying business administration. She presented with transient right hemiparesis. This was a huge left parietal AVM coming from the surface, going almost up to the ventricle. This is the bleed around the AVM, which caused the transient limb weakness, which improved spontaneously. She had incongruous homonymous hernianopia before surgery itself. And this is the angiogram showing the AVM and the venous drainage. Spatzler-Martin grade 4 AVM. Preoperative embolization was done. The big feeders could be taken care of, but the small feeders, which is the bugbear of the surgeon, the interventional radiologist said it's very difficult to embolize, and they had to be tackled by surgery. And this was a long surgery. At the end of the surgery, there was intraventricular hemorrhage, which required a re-exploration. An external ventricular drain was put. The patient was on ventilator for a few days. This is the post-operative angiogram showing complete excision of the AVM. And this is on follow-up. She successfully resumed her MBA studies and now is doing her job after being selected at campus. So this is my series of about 20 cases. It's a small series. So only one patient had a complete hemiplegia before surgery, and that hemiplegia persisted after surgery too. There were some intraoperative complications, but like hemiparesis, drowsiness, but they all improved after appropriate treatment. And most of the patients made full recovery. But a few patients, 2 or 3 patients have psychological problems, which is interfering with the work-life balance. These are the complications. These are the presentations. 8 patients presented with bleed, 6 with seizure, 6 with headache. 3 patients had hemiplegia before surgery. 2 of them resolved completely. 1 patient had dysphagia, which resolved. altered sensorium in 2, which recovered, hydrocephalus in 2, resolved after AVM excision. 1 patient was on EVD. New onset deficit, 1 patient had post-ictal leg weakness after surgery, which improved. 2 patients have persistent psychological issues. 1 patient, which was a CP angle AVM, had tinnitus before surgery. Even after complete excision of the cisternal AVM, tinnitus persists in this patient. And he has hearing in that ear, so he's not willing for any destructive procedure to cure his tinnitus. So careful case selection is the key. The advantage of microsurgery is immediate elimination of risk of rebleed as compared to gamma knife surgery or focused radiotherapy, which may require a period of 1 to 2 years for elimination of the AVM. And in AVMs which have bled, they're exposed to rebleed during this period. And in my previous institute in Sri Chitra, we had quite a few cases which were given focused radiotherapy and rebled in the waiting period. Preoperative embolization is useful in making surgery safer. Thank you very much for your patient listening. It's an honor to be presenting here. Thank you.
Thank you very much. It was a great presentation, and I agree that multimodal management can, including endovascular treatment, surgery, and radiosurgery, can certainly increase the outcome, particularly in the long run. I think the message regarding some aneurysms that are associated with the AVM becoming dormant after full excision of the nidus. I see why you say that this might be a bit controversial, but this is something that from time to time we experience in clinical practice, and obviously it really depends on what are the options that can be offered safely to the patient, and so I think this is the message you wanted to pass, correct?
Yes.
Yeah.
Thank you.
Very, very great cases. Congratulations.
Thank you.
Thank you. Ravi, can I ask you,
Of course.
did you use a microdoppler detector for determine between feeding arteries and the veins? Because the veins and feeding arteries has same color. They are in red color. Do you use microdoppler, or you use only your experience for determining?
That's a very good question. We use microdoppler. We have microdoppler and we use it generously. But the problem I face is sometimes even in the vein there is pulsatile blood flow. So actually differentiating it from artery may sometimes be difficult. I have 2 ways of identifying the feeding arteries safely. One is navigation, of course, which we use to identify all the feeding arteries and sequentially go near them and ligate them as close to the AVM as possible. The second is I use fluorescent angiogram before ligating the artery. And what I have seen is there is a microsecond faster entry of dye into the artery than into the vein. So it's very subtle. You have to be very quick in catching that. So the dye enters the artery first, followed almost immediately by the vein. So I use these 2 methods to identify the arteries first.
Okay, thank you so much.
How did you find the Doppler? Do you think it tells you the difference between arteries and veins?
And I use Doppler to identify it, and sometimes I use ICG for identifying. Yes, and you use a fluorescein.
Yeah.
Is the fluorescein is better for identifying feeding arteries?
Yeah, the fluorescein, the issue here is fluorescein is very cheap. It's used in ophthalmology, so it's widely available. and never runs out of stock in our country. So we have the fluorescent filter, 800 nanometer filter, which we use. And I find that in AVMs, it's AVMs and aneurysms also post-clipping to identify the patency of perforators, etc., to be very good.
Thank you so much, Ravi.
Thank you.
Okay, Ilya.
Yeah, Ravi, please, I have one question. For a patient with acute ruptured AVM, do you use a two-stage approach? For example, the first is the decompressive craniectomy or partial removal of the intracerebral hemorrhage, and the second stage operation in 1-2 weeks or something like this to remove AVM? Or do you advocate the one-stage surgery for acute clot removal and removal of the AVM needles?
This is a very good question. In the previous institute where I was working, we have used two-stage surgeries where we remove the clot, provided the patient is stable. And we do the surgery second stage a few days later or 1 or 2 weeks later, as you suggested. In my present practice, I'm using a single stage approach. We have not yet had a patient who had a catastrophic bleed, which was life-threatening, requiring evacuation of the hematoma first, even before any studies could be done properly. So the most of the cases, all the cases have been single stage in the current practice.
Even for high-grade AVMs?
We don't operate so much on high-grade AVMs. I've done only one grade 4. The rest of the AVMs are grade 1, grade 2, and grade 3A.
Thank you very much. And I want to ask this question to Dr. Dubovay and Maria. What do you could advocate for this patient? One-stage method or two-stage method? Let's have a small discussion about this.
Thank you. Yeah, it's a very good question. I think the better method is to combine endovascular approach to occlude main feeders to reduce the blood flow velocity inside the nidus of the AVM, and then to perform a microsurgery stage. I think this is a better method than use only one microsurgical or endovascular treatment.
Yeah, I will give a different answer. So did my training in Verona, which is a very big radiosurgery center, and our patient oftentimes had multi-stage treatment, which included initial endovascular treatment, microsurgical resection, and then if there was an incomplete resection, radiosurgery afterwards. And we have developed a number of techniques to reduce the side effects of radiosurgery. I remember one of my very first research was on reducing the damage to the pyramidal tract in young kids that were treated with radiosurgery for AVM in close proximity to the pyramidal tract, and we managed to reduce significantly the unwanted radiation exposure to the white fibers, and as a result improve the clinical outcome of those kids. So I would say I'm very much open also to multi-stage treatment where you have the 3 options fully considered for patients, particularly if they are very complex AVMs, and I believe that ultimately a good decision making is the center of the management. You need to involve patient in discussing all the pros and cons of the various modalities, explaining that basically only surgery will allow complete excision and removal of the problem. And for those patients with a residual AVM, residual nidus requiring some radiosurgery treatment, you have to explain that unfortunately by the time they are treated, they will have to wait at least 2 years, 2.5 years before they see the result and the disappearance of the malformation.
Thank you. And Ravi, you have really fascinating microsurgical skills, and I could agree with you that if you have good experience with AVMs, I think you could remove the grade 1, 2 AVM in one stage, but there is only one problem. If there is big intracerebral hemorrhage, and we perform one-stage surgery, there could be a partial AVM removal because of the mass effect on the afferent or efferent arteries or veins, and they could be occluded by the clot. And we don't see the full AVM in the initial rupture. You could evacuate the clot, then remove the malformation, then redo an angiography in 2 weeks, 4 weeks, and saw a small partial AVM that was occluded in the initial rupture. Maybe that's why there is the problem with the one-stage acute stage surgery.
Yeah, I agree with you. That concept is there that a large hematoma can partially occlude an AVM. Definitely. So we have followed both policies. We have done 2-stage surgeries and we do single-stage surgery. I guess the situation you are mentioning is a large bleed which is life-threatening.
Yeah.
So I think there evacuating the clot becomes paramount because you don't have time for planning. You don't have detailed angiography, detailed embolization or radiosurgery. You don't have time for any of these things. So there the policy of evacuating the clot first, provided the AVM allows you to come out without trying to resect it. So that policy can be followed, and we definitely have followed that in a few cases. I agree with you.
Thank you. Mario?
Okay.
Yeah, just wanted to add that this is precisely the scenario that I was considering when I say multi-stage treatment might be required, and you never know that you have completely resected the AVM until you have the post-operative angiography. So this is a given, and only after the post-operative angiography you can tell patient has been cured, or you might elect for adjuvant treatment afterwards.
Yeah.
Thank you.
Sometimes when I saw the angiography of AVM, I think that it could be a subject with the intellect that we need to fight with. Thank you very much.
Okay, we have to move on to the next lecture. Thank you, Dr. Ravi. And could someone introduce the next speaker, please? Ilya or Mario?
Yeah, I would like to introduce Jakub Czerwacki. He's our invited speaker from Georgia, a very good friend of mine. Is going to present case-based decision-making on endovascular versus microsurgical treatment for aneurysm. Jakub, the floor is yours. Thank you very much for being here today. And I think, can you unmute yourself, Jakub? Good.
Okay. Now is it okay?
Yeah, you're in business. Go ahead.
Perfect. Perfect.
Okay. 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 First of all, thank you, dear Mario, to invite me here. For me, it's a great pleasure and great honor to be here to listen great presenters like our colleagues from India, from Russian. My talks today is about dual train neurosurgery. Well, as we know, today is a great debate about dual train neurosurgery, how to train neurosurgeon. It's a big task in world neurosurgery. Is it really possible? Is it really really necessary? I want to charge. Sorry, I want to charge my laptop. Sorry, because it's. Okay, it's okay. It's really need to teach a neurosurgeon interventional skills. Maybe it's not necessary because already neuroradiologist is great. Today, I want to show how to personally. I am going to choose which patient is for open surgery, which patient is for endovascular treatment. As you see here, two lines, blue lines from 2004. Clipping rate is 2 times more than endovascular, but in 2006 it was pretty similar. And from 2007, endovascular treatment rate is higher, and nowadays it's 2 or 3 times more than microsurgical techniques. Pretty similar is for unruptured cases. From 2004 it was equal, but from 2007 rate of endovascular embolization is higher than microsurgical reconstruction or clipping. Does neurosurgeons that perform both open surgical and endovascular techniques is safe and effective? It's one of publication from short-term outcome of clipping versus coiling during the rupture intracranial aneurysm. It's from USA. And this publication says there was no difference about outcome after endovascular embolization and microsurgical clipping. What's about in Europe? In Europe is more complicated because nowadays neuroradiologist is more powerful. They are doing great job. And first publication about dual trained neurosurgery was from 2014 from Netherlands, Bogarts, treatment of patient with ruptured aneurysm by neurosurgeon. They show the results, and the result was pretty similar as the USA. And the guys, which one is doing both, perform both surgery, endovascular and open, so the result was the same. What's about training? Training is one difficult task nowadays, but as we know, INS is working hard to improve training system for neurosurgeon, which one will be, and they will have possibility after training to start endovascular way of treatment. They have nowadays some teaching program, some guidelines how to neurosurgeon can start endovascular way of treatment. Of course, for neurosurgeons, it's a different kind of surgery. It's require different type of skills, and it's completely different. If you compare any kind of neurosurgical surgery, neurosurgical skills to endovascular skills, it's completely different, and it's require training program. Personally, first my fellow was in Mannheim University Hospital, 2015, with Professor Schmidek. I was a little bit lucky. After he was retired, he arrived in my hospital, and we worked about 2 years, and he helped us to develop neurovascular comprehensive center in our small city. Same time, I had many different courses, many different fellows in neuroradiology department. For example, in Valdebron, Barcelona University Hospital, some small fellow in Borough University Neurosurgical Institute in USA. But where is the line? Where is still is no consensus? Is it necessary to neurosurgeon can do both kind of treatment? I will show you how we are going to find patient which one is more for endovascular or for open surgery. For, of course, a young patient with hematoma or hemorrhage, mostly for us or for open microsurgical approach, and for posterior circulation, rupture aneurysm, we are doing endovascular embolization, because it's more easier, more faster than if you compare open surgery. A very famous publication about Borough 10 years results, and this publication shows there was no difference about poor outcome, but there was many difference about retreatment rate of retreatment rate after treatment. As you see here, clipping cohorts, they had a 0.8 retreatment rate, and in clipping in a embolization series, they had more than 20% of embolization retreatment rate. I show you some of my patients. Patient is a 67 years old female, 5 days after acute headache. Patient had a subarachnoid hemorrhage, Hunt's 2, GCS 15. You saw here some subarachnoid hemorrhage near the ACOM territory, also some hemorrhage, some subarachnoid hemorrhage in sylvian fissure. After CTA revealed ACOM aneurysm and MCA right MCA aneurysm. Also small contralateral MCA, maybe non-rupture aneurysm. What was the next step? Next step, we have a police. If we are going to discuss which approach is better, always we are doing DSA, 3D reconstruction DSA. And as you see here, patient has a complex right MCA aneurysm and small ACOM aneurysm. Still, we don't know which one is the rupture. Maybe contralateral side, mostly not rupture one, because hemorrhage is more in right sylvian fissure. What is it best option? One option, of course, is clipping. We can clip aneurysm, and we can use one stage approach to clip both MCA and same time ACOM. Okay, some guys is doing even contralateral MCA approach, but I don't have experience to do from one side clip contralateral side aneurysm. What's about endovascular view? Endovascular view, we can do MCA balloon remodeling technique. Mostly it's required to balloon because aneurysm is wide neck. Some guys is doing it to partial embolization, and the second stage maybe flow diverter or braided stent. And same time you can do balloon embolization for ACOM aneurysm. But in this case, if you even do double balloon remodeling, you need definitely second stage approach to put stent in this region. That's why we decided to do open surgery. Mostly nowadays we are using lateral supraorbital approach, even for cosmetic reason. Classic, you can see now classic terminal approach.
after opening of basal cistern, we are using a simple neurosurgical dissection maneuver with micro scissor, bipolar, and dissector. You can see after relaxing of brain, we are going to open distal sylvian fissure. Before opening distal sylvian fissure, we would like to have a M1 proximal control. If in case of rupture of aneurysm, we are putting temporal clips. And now we are going, we are using highest magnification sitting position, and we would like to use a mouthpiece to focus and refocus without using our hands. I will be more fast. You see here a complex MCA bifurcation aneurysm. We are going to dissect every small branch from aneurysm, and it's possible with a sharp and blunt dissection. After dissection of all branches, we have control of proximal M1, and during proximal M1 temporal clipping, we are doing multiple clipping technique to clip different each lobe of aneurysm and reconstruct neck to save flow. Both M2 division. Of course, you need microdoppler or ICG or fluorescein green nowadays. Mostly we are using FL516, and as my colleagues from India mentioned, fluorescein is more cheaper, and when you are living in developing countries, you have limitation of materials. That's why nowadays we use 516. You can see here booster clips near the neck. It's a fenestrating because force of clipping is more for fenestrating clips. Still, Doppler, I like very much Doppler. There is one problem. When you use one time fluorescein green, to use it second times, it's not more informative because you have some remnant inside of vessel. Now we are going to treat acomaneurysm. Most probability it was a ruptured one, and you have during the before temporal clipping I have ruptured, but it's no problem. We should stop our suction near the rupture point. Then I'm going to put temporal clip ipsilateral A1, then contralateral A1. After relaxing of flow and decreasing of bleeding, I have more time to put pilot clips at least to stop bleeding. You can see here, and after stopping of at least decreasing of bleeding, I have more time to do more detailed inspection, and if it's necessary to change the. Okay, now I'm doing final inspection, and I saw that aneurysm is partially clipped. That's why I'm decided to change the position of my clips. And nicely you can see jugular artery, ipsilateral A1, contralateral A1, both A2 segment. And now I have more time to do final job, contralateral temporal clipping, ipsilateral A1 clipping, and then I'm going to change the. And now you can see very easily how partial I clipped first time. And now I'm going to change my position to use a different curve clips. What's the benefit here to be dual trained neurosurgeon? I did control CT, and same day I did, because already I had a small introducer inside of femoral artery, and I did control 3D reconstruction DSA, because without 3D, sometimes you can leave some part of aneurysm without clipping, and it's very easy. You have already even you don't have hybrid operation room. You can change just one room to second room. You can do control DSA if you need to make reposition. You can do without any problem. Okay, what's about second case? It's 40 years old female, sudden onset of headache. Hunter 3-4, GCS 13-14, Fisher 2-3. You can see subarachnoid hemorrhage. Subarachnoid hemorrhage is in both sylvian fissure and basal in basal cistern. According to these images, you cannot say which MCA is a rupture. Patient is very young, 40 years old. Okay, I don't like, we are neurosurgeons, we like open surgery, we don't like for MCA to do endovascular embolization, but maybe all one agrees it's no one can say which one is a ruptured. You can see right ICA injection, from right ICA injection, right MCA aneurysm, and from left ICA you can see similar ICA aneurysm, and subarachnoid hemorrhage is pretty similar. What's the strategy? Clipping to stage, 2 incision, coil embolization, simple or balloon remodeling. What I did, of course, I did in this time balloon remodeling technique, and balloon can save patient and can save doctors. Why? Because as you see here, we had an intraop rupture, and we used balloon, and during the balloon we did fast coiling, and then the approach in the contralateral side, and as you see here, 2 weeks after control CT, patient was without any problem, without any delay, ischemic changes, and you can see 6 months follow-up. Okay, maybe there is some residual, but we can follow if there will be reperfusion. We can do braided stent or flow diverter, but mostly for young patient, this kind of remnant or some residual, I would like to use braided stent. What's about ACOM territory? You can see 30 years old, Hunters 2, GCS 14, multiple brain aneurysm, rupture 1, maybe not maybe, there is no question, is ACOM aneurysm is ruptured because you have hemorrhage interhemispheric fissure, and you can see large, like more than 50 millimeter aneurysm. We did 3D reconstruction. You can see 2 MCA territory aneurysm at the same time, very complex ACOM aneurysm. What's a treatment option? Balloon remodeling, embolization, or clipping? What we did just balloon remodeling, first stage. You can see maybe there is some remnant, but it's no problem. We can do as a second stage braided stent in ipsilateral A2. What's about flow diversion in acute stage? There is no consensus about flow diverter, because you should risk contralateral territory, contralateral A1, contralateral A2 when you are doing a flow diverter. And okay, if you don't have any option, you can do rescue stenting, but you can do as a first stage balloon remodeling, and then you can put stent. At the same time, we had a 46 years old male, Hunter's 2, multiple brain aneurysm rupture. Rupture one is a giant ACOM, but patient had a progressive vision loss. I think there is no way to do coiling technique because already patient has a vision problem. If you put some mass here, you will increase progressive vision problem. That's why we have decided to do open surgery. It is not easy surgery actually. I think it's very, very complicated when you have acute subarachnoid hemorrhage and when you need to do clipping, this kind of surgery. As you see here, before rupture, it's not working because you have sleep during the clipping. As you see here, bigger coils, bigger clips have less forceps of clipping. That's why we have decided to open aneurysm to be more softer, and then we are going to use fenestrated clips and remodel anterior communicate territory. You saw and after microdoppler, we are going to use a fluorescein green FL560 to show flow both A2 segment because during this surgery it's high risk to have less flow in a A2 segment, and it's after surgery. Another case is again multiple aneurysm, ICA terminate large aneurysm. At the same time, patient has ACOM and contralateral MCA. What was a good option for this case? Okay, maybe we can do clipping, but there is some you can see here anterior choroidal artery adhered from aneurysm very, very close. To control this branch, I think not so easy. That's why we have decided to do balloon remodeling technique to put coils inside of aneurysm during the balloon balloon inflating. And as you see here, despite of you have a big hole here, and here is a high risk to protrude these coils inside of ICA. If you use a bigger balloon, you can reconstruct very nicely this kind of aneurysm. And we did 2-month follow-up, early follow-up, because it's a large aneurysm, and always mostly after 3 months you have reperfusion. But surprisingly, we did not have any reperfusion signs. That's why we have decided to treat contralateral MCA and ACOM aneurysm. What's a good choice for this aneurysm? Some of my colleagues, neuroradiologists, like a simple way to put one flow diverter from M2 to M1. But as a neurosurgeon, I don't like to cover 2 big branches. But neuroradiologist says it's no risk, and after 6 months you can see nice remodeling of MCA territory. But when you know that you can clip, it's very easy. You don't need to put flow diverter, or if you are going to put flow diverter, you need balloon test. If you have good leptomeningeal collaterals, maybe you can put. But I did mini-invasive approach, supraorbital approach, just mini-invasive, just distal opening of Sylvian fissure. Even I don't want to put temporal clipping of M1 because I know it's non-rupture. Brain is very relaxed. That's why I did just a mini opening of distal Sylvian fissure. and reconstruct MCA aneurysm with multiple clipping technique. At the same time, also I put one clips in ACOM aneurysm. But okay, you can see here the 40 years female. 5 years ago, we treat with a balloon remodeling technique. She had 5 years ago rupture subarachnoid hemorrhage, but after control DSA, we saw reperfusion, recanalization. Patient is very young, 40 years old, beautiful woman. She did not want to have an incision. That's why we have decided to put a smallest flow diverter near the aneurysm, and we have used smallest profile flow diverter, like 3.5, as I remember, 3 to 15. And you saw, as you saw here, we have nice deployment of flow diverter. It's just a half-hour operation. Okay, next case, and it will be last case. 62 years female. It was like 2 weeks ago in my department. Hand has one very light headache, and as you saw here, the patient has a complex left MCA aneurysm. Some branch emerged from MCA aneurysm sac. Maybe it's a trifurcation. It looks like a middle trunk. It's not good idea for endovascular treatment. Even we did not use DSA in this case. It's for us is enough to do clip reconstruction. And we told our nurse, please make ready. Maybe we need flow reconstruction. As you see here, okay, after basal cistern opening, we have started to open proximal M1. Okay. In this case, when you have complex MCA aneurysm and it's a ruptured one, almost we would like to open very wide sylvian fissure. Okay, if it's non-ruptured, we don't need to open like this. Just distal sylvian fissure opening is enough. But in this case, we already opened this proximal M1 to have a ready and to check which kind of temporal clips and which angulation we need. After that, we have started highest magnification dissection of distal sylvian fissure. You saw here anterior temporal artery and complex MCA aneurysm. As you see here, middle trunk is coming from aneurysm, and there is a superior division. In the left side, there is a bifurcation of inferior division, and there is a middle trunk. How to preserve this vessel? One way, I think, one solution is to do flow reconstruction, because okay, you can use multiple clipping technique, but it's mostly impossible to preserve flow inside this branch. That's why we have decided to do side-to-end flow reconstruction. As you saw here, we have made ligation of proximal middle trunk artery. After fish mouth cutting, we have done bypass surgery, 10-0 ethanol suturing. After bypassing of this vessel, we have checked flow inside recipient and donor artery. Of course, we used microdoppler, fluorescein green, and small leak we can stop to be with a Surgicel or hemostatic sponge. After that, it's more easier to clip this type of aneurysm. I have used multiple clipping technique to reconstruct neck, as you saw here. I'm using different type of clips. Sometimes a Pernetsky type of clips. Sometimes, because as you saw here, Pernetsky type of clips, micro clips, is more softer, and this side of aneurysm is more weak. Now I'm going to use Yeşilgil type of clips. Even final clips is a curve fenestrated, because near the neck you can see atherosclerotic changes, and to clip this type of aneurysm you need more force. Then checking again flow and starting to dissect both A1 segment. Mostly I don't like to use rigid retractors, and you don't need. Even you don't have enough space to put a rigid retractor. Just dynamic retraction is enough, and we use sucker and suction retractor, dynamic retraction, and bilateral temporal clipping. After that, we can use the rigid retractor, just final attacking of aneurysm. After gyrus rectus resection, we are controlling both A1, Hübner, and during the dissection of ACOM territory, you can see we had a rupture, but it's no problem, because both A1 is already controlled, and we don't have catastrophic bleeding. You can see now we are doing just pilot clipping to stop bleeding. Then we are going to relax flow and make final inspection. If we need to change a position, we have more time. Now we are doing final inspection, both A1, A2 segment, Hübner, and we saw that we have some remnant near the neck. You can show you small remnant. After final inspection, there is some remnant near the neck, and we have decided to change the position of neck, the clip. Sorry. After temporal clipping, contralateral A2, contralateral A1, ipsilateral A1, and then Pernetsky type of clips.
Excuse me, Jacob. Jacob, we have to tighten up on time. Okay, so could you wrap it up?
Thank you. It's our results. We have done more than 500. It's not updated now. We have done more than 500 rupture cases. Thank you. Sorry if I was.
It was wonderful, Jakob. Thank you very much. Thank you very much. Challenging cases. I think a good discussion about the multimodality approach and an indication for endoscopic, for endovascular versus microsurgical, or both of them, and also all the technical nuances that you have shared. Very, very, very useful for our attendees. Thank you.
Okay, I'm sorry, we have to move on to the next speaker. Ilya or Mario, could you please introduce the next speaker?
Yeah, the next speaker is the Dr. Rasim Agaev from the Novosibirsk Neurosurgical Center. Rasim, please go ahead.
Hello, everyone. Thank you for invitation. Just a second, please.
Okay, we can see it, not full screen, just put it on presentation mode. Novosibirsk, we finally got a speaker from Novosibirsk.
Yeah. Could you see everything? It's okay?
Yeah, you have to make it presentation mode. It's at the very bottom. Where you
Okay,
got,
okay.
yeah, at the bottom and make it big screen, yeah. There we go, perfect.
Perfect. Thank you.
Okay. Thank you for invitation. This work I've done with my mentor, Andrei Vladimirovich Dubovoi. By the way, hello. We do today. Today I'm going to tell you shortly about the effectiveness of using various types of bypasses for complex MCA aneurysms. As you know, middle cerebral aneurysm represents about 50% of all intracranial aneurysms, and giant MCA aneurysms account about 5%. So what we mean when we talk about complex aneurysms of MCA, it's always wide sclerotic and calcified wall and neck, multi-chamber, also could be with M2 branches arising from the dome, partially thrombosed or previously treated aneurysms. And the important one is the size, like more than 25 millimeters. Some complex MCA aneurysms cannot be safely occluded without risking the parent artery or the branch vessels. So because of it happened because of incomplete closure of clip jaws, clip dislocation, thrombosis of the cerebral arteries and branches, or distal thromboembolism, perforating artery occlusion, and brain tissue injury. And depending on the size and the type of aneurysm, there are several methods of surgical treatment. As you know, we could do aneurysm clipping using various types of bypasses or endovascular treatment. In case where high risk of ischemic complication is known, bypass is required to prevent these complications. So what we could use, it's this type of bypasses. Low flow bypass, when we do STA MCA, it's single or double barrel. Middle flow bypass when we do between IMAX and M2 by using the radial artery or venous graft. Third one is high flow bypasses when we do bypass between extracranial external carotid artery and M2 branch. Intracranial also, intracranial, and a combination of different type of bypasses. So we done a lot of these surgeries in our center, and at one moment we decided to study the effectiveness of using these types over the past 10 years in our center, and also we done a literature review. What we done is retrospectively analyze the data of patients in our center and literature review. So total of 82 patients were selected from our center and 18 articles, from which 298 patients were selected. What we got is from these 82 patients, half of them had saccular aneurysm and half of them fusiform. 43 aneurysms were thrombosed, 22 aneurysms ruptured by the time of surgery. A total of 7 high-flow anastomosis were performed, 3 of them by using a low-flow protective anastomosis, 11 intracranial anastomosis, 74 low-flow anastomosis, of which 49 was single barrel and 25 double barrel. The mean occlusion time was 30 minutes. In our group, bypass was patient in 80 patients, and occlusion occurred in 2 cases. For sure, there no way without complications. So in our patients, we have total 17 complication cases. In 13, it was ischemic complication postoperatively, manifested by focal neurological deficit. 2 of them underwent the creation of high-flow anastomosis, and 8 was low-flow single-barrel anastomosis. And the 3 was double-barrel anastomosis. Also, there was 2 hemorrhagic complications. 1 patient developed a hematoma in the cilious fissure due to insufficient hemostasis of the lateral branches of the radial artery. And the second patient had a hemorrhagic lesion in the left frontal lobe due to the formation of a venous infarction due to coagulation of the veins of Sylvian group. But this case did not require surgical treatment, was conservatively. And results of literature review of the it was found that the anastomosis was maintained in 271 patients, and occlusion occurred in 27 patients. A total of 58 cases of complications were identified. The most common also was ischemia of brain regions in 33 patients. Postoperative hemorrhage in the form of subarachnoid hemorrhage, subdural hematoma, and intracerebral hematoma were detected. Also, we categorized a group of other complications. It was 15 patients, included 2 skin necrosis due to sampling of the superficial temporal artery, 5 meningitis, 6 pneumonia, and 1 deep vein thrombosis, and 1 vasospasm with cerebral edema. So in conclusion, we want to say that bypass is useful technique with acceptable frequency of morbidity and mortality when conventional surgical or endovascular techniques are not feasible. These techniques allow us to expand possibilities of surgical treatment without losing of radicalism. The treatment of complex MC aneurysm using various types of bypass has good results with a minimum percentage of complication. But it's also worth considering that complexity of the operation, which requires good preparation and more practice by the surgeon. That's all. Thank you very much for everyone for listening.
I'd like to thank you very much. Unfortunately, we don't have much time for questions. Rosine, put your email address in the chat, and anyone that has a question can email me you, okay?
Okay, thank you very much.
And that's great to have someone from Novosibirsk. Stay in touch.
Thank you. Thank you.
Okay, Ilya, could you take over, please?
Yeah, Mario, could you please introduce the last speaker? Oh, I could introduce Dr. Evgeny Zhukov from the Almaty, Kazakhstan. His topic is combined treatment of multiple cerebral aneurysms. Dr. Evgeny, please go ahead.
Okay, thank you.
We don't see the full screen.
Okay.
Yeah, there we go. Okay. You're in the right area. It's one of those 4 icons.
Yeah.
Try the other icons at the bottom where you were. There's a couple more icons. There you go. Perfect.
That's
perfect.
okay.
Perfect.
Okay. Is everything okay?
Yes, it's very good. Thank you.
Okay. So hello everyone. Hello colleagues. I would like to thank you for the opportunity to share our experience from our country. My name is Evgeny Zhukov. I am from Almaty, Kazakhstan. Work in City Clinical Hospital number 7, where we have Neurosurgical Center. So recently, cases of patients with multiple aneurysms in our practice have become more frequent. So I want to share one of them with you in my short presentation. It's look like a presentation of Dr. Jakob. So, but first of all, I want to say a few words about our neurosurgical center. It includes 105 beds and departments like neuro-oncology, vascular neurosurgery, spinal neurosurgery, and neurotraumatology department. So this is our vascular neurosurgery team. We are not divided on interventional and neurosurgical specialties. So we are universal vascular neurosurgeons, and we have also 24 hours emergency neurosurgical stroke treatment. So about our indicators, we do about 600 operations per year, 40% emergency. As said Dr. Jakob, endovascular treatment is leading variant of treatment in our clinic too. So 70% endovascular operation and 30% microsurgical operation, including emergency. And I have one case report. So moving closer to the topic of my report, I want to present a case, female patient, 40 years old, who emergency hospitalized in other clinic with subarachnoid hemorrhage, which accompanied with cerebral vasospasm, headache, and general weakness. So she was very lucky to discharge after 14 days without strong neurological deficit and without operative treatment because of not conditioned for make operative treatment in our in the other clinic. So when we entered in our department, complaints continued with headache, general weakness, still no neurological deficit, and no any CT scan on her hands. So we started diagnostic from DSA. Cerebral angiography confirmed multiple cerebral aneurysms on M1 segment, right MC aneurysm, ophthalmic segment, left internal carotid artery aneurysm, and left MC bifurcation aneurysm. So this is DSA from the right side. We see here M1 segment small MC aneurysm, which with a gravitical. This is DSA from the other side. So here we can see in the ophthalmic segment left internal carotid artery aneurysm, and you can also see the bifurcation aneurysm with complex configuration. So here is a 3D angiography from this aneurysm. And so what is the decision considering localization of multiple cerebral aneurysms, subarachnoid hemorrhage in the anamnesis complex configuration of left MCA bifurcation aneurysm? Our decision was the first step in the vascular embolization with coils and white MCA from the right side, and the ophthalmic segment left internal carotid artery aneurysms. And to the next step, to do surgery, clipping left MCA bifurcation aneurysm. So we started from endovascular treatment. First of all, we make balloon-assisted coiling of M1 segment right MCA aneurysm. Here we can see the working position of embolization. On post-op DSA, we can see no complication after embolization with aneurysm. So the next step we go to the other side and make embolization of internal carotid artery aneurysm with balloon assistance. On post-op DSA, we also see no complication, and the next step, the next stage will be the surgery. So on post-op CT, after embolization, we also can see there's always good. So the next stage of the treatment is neurosurgical clipping, left MC bifurcation aneurysm. It was a standard perineal approach. So we started from the ciliary and fissure dissection. We see some problems after subarachnoid hemorrhage to go to the aneurysm. Then we made 1 and 2 segment dissection. Then temporary clipping in 1 segment to make an aneurysm dissection. After that, when we saw M1 and M2 segments of MCA, we made clipping. So DSA after clipping like that, aneurysm is clipped, and there are no recanalization of this aneurysm. On this DSA, we also see like positional clips, and this is DSA 3D picture after clipping. So the patient was good outcome, discharge after 12 days without any neurological deficit. And in the conclusion, I want to say that the desire for minimal invasiveness and maximum safe and complete care for patients need a comprehensive approach to treatment of multiple cerebral aneurysms. I would also like to inform you about the annual conference in Almaty, where you can share your experience with our and foreign colleagues, and we will be very glad to see you in Almaty, and you are always welcome.
Thank you.
If you want to know more information about our work or update information about the conference, so you can follow us in social media and write me on email if you want. So thank you very much for your attention. It was very glad to see you and meet you. Thank you.
We have a few minutes for discussion if you want, Mario.
Just wanted to check. Can you tell us a little bit more about the neurosurgical department you're working in Almaty? How many surgeons you have? What the volume, the case mix? Just those type of information.
Okay, so we have 7 doctors. 3 of them are emergency neurosurgeons who work 24 hours a week. So and we make vascular surgery about vascular pathology of the head, of the neck. So probably it's more in the vascular treatment. So maybe the next time I will tell more about endovascular or more about our microneurosurgical experience. So, it's about 600 operations per year. We have 20 beds. So all of these beds are always work. So we have an emergency care. So every day we have emergency operations for about the ischemic stroke or hemorrhagic stroke. So
you are also a stroke center, I suppose, correct?
Yeah, correct. Right.
Ilya, you have a question?
No, it's a great presentation. Speaking about the AVMs, cavernomas, and aneurysms is all that I want today.
Oh, okay. Okay, very good. Thank you all, especially for understanding about the time constraint. They were great lectures. and I appreciate your enthusiasm and your time. And we hope to see you in 2 weeks. We're going to have another Russian Grand Rounds.
Thank you very much.
I tell you again, thank you all you guys. Thank you very much.
Thank you.
Thank you.
Thank you.
Bye.
Thank you so much. Bye. Bye. Bye.
Bye bye.